Perfect. Good morning, afternoon, and evening to everyone. I'm Brittany, one of the fellows at Jackson. And today we have a case to go through about penetrating trauma involving the mediastinum. It's a case I did last month with Dr. Ruiz. So he's on here, so he may have some stuff to add in as well. So on arrival, the patient, it was a multi-victim incident. One of the patients was dead, declared on scene. There are other patients coming in with gunshot wounds to the abdomen who were going straight back to the OR. This patient was a 20-something-year-old female. She presented with a gunshot wound to the right shoulder here. And then there was a superficial wound on the left breast. And the backup trauma surgeon, who was actually Dr. Ruiz, was en route. So going through ATLS, her primary survey, her airway was patent. She had bilateral breath sounds, auscultation. Her heart rate was 97, systolic 160. Breathing 22 times a minute, GCS was 15, pupils were equal, round, and reactive. For adjuncts to the primary survey, she got a chest x-ray, which is pictured here. So you can see a right-sided hemothorax, and then you can see a projectile in the left upper quadrant. And this line kind of traces out the presumed trajectory of the bullet. So we placed a right-sided chest tube, which you can see here. You can see there's still a retained hemothorax on this x-ray. The initial output of the chest tube was, there was some on the bed, maybe 150 or so in the pleurovac, and then another 50 to 100 on the bed. And then again, the red line shows us the paper clip that was marking where the gunshot wound was noted in the right shoulder and the trajectory of the projectile in the left upper quadrant. So for our first question for the audience, I guess the Zoom poll isn't working, but we just have the multiple choice question on the next slide. So based on the clinical condition and the x-rays provided, what is the next best management strategy? So going to the OR and performing an exploratory thoracotomy, going to the CT scanner and obtaining a CTA of the chest and abdomen, going to the OR and performing an exploratory laparotomy, or obtaining an esophagram and an EG.
Dr. Ontrak, do you want to take the question first?
Sure. So it's basically stable patient after arrival, and on the on that upright, I think it was an upright chest X-ray. It looks like there's a little pneumoperitoneum under the left hemidiaphragm. Yeah, right there, right over there, exactly. So, and with a stable patient, I put in 2 IVs. Draw a red top tube, and then go to CT scan in this case, chest and abdomen. Chest and abdomen with IV contrast, you can do the CTA, that's fine. But CT in this case.
Okay, thank you, Dr. Ontrak. Dr. Supa, do you have something different to add to the scenario?
I agree with sending this patient to CT scan because his vital signs became stable after resuscitation and right chest tube. And I think CT scan would change management. It could rule out intrathoracic injury that need surgery, like mediastinal vessel injury. If the right chest tube doesn't put out much blood out, and she doesn't have mediastinal injury, we can focus on the abdomen. But if she has like a mediastinal vessel injury, you could plan your chest incision based on the CT result. Thank you.
Perfect. Thank you, Dr. Supa. I don't think we have any other panelists except Dr. Ruiz. So would you like to add something?
So tough decision. I'm going to be honest with you. Kudos to I was the backup person. I was on my way, probably 5 minutes out, and we were discussing this while I was driving on my way to the operating room because the attending and Dr. Nowak were in the operating room right now at this point with the other patient. But it's a tough decision. Excellent observation about the pneumoperitoneum. Excellent observation. That's tough to catch for a lot of trainees. But assistant surgeon obviously pinpoint right away. The one piece of information that you need to go to CT, in my view, is to be sure that there's no hemopericardium. That would be the only piece of information. Now, because of the fact that the patient has a hemothorax, If there's no hemopericardium, that negative is not completely ruled out. But if there was any fluid in the pericardial sac, I would definitely not go to CT scan and go to the operating room right away. But I think given this information and the fact that the patient's vital signs were normal and the chest tube was in place, going to the CT scan gives you valuable information on operative planning. So it's a tough decision, but I think going to CT with the information of a negative pericardial ultrasound would be the way to go in this case.
So that's what we did. We have some images here from the CT scan. So this first one, you can see kind of where the trajectory starts, the retained right-sided pneumothorax. And then you can kind of follow the trajectory across the median sternum, air around the esophagus or there. The red track kind of indicates the bullet trajectory. So you can see it went through the stomach here. And then where it lodged, kind of in the left upper quadrant. It's kind of hard to see the colon here, but the colon is nearby. So the CT scan, here's our coronals. Again, the red line marking the trajectory. The right-sided pneumohemothorax, fluid and air around the distal esophagus, a trajectory through the stomach, through the splenic flexure, and then the projectile lodged lateral. So another question for the audience here. So based on that imaging, what would your preferred surgical approach be? So exploratory laparotomy, right thoracotomy and exploratory laparotomy, left thoracotomy and exploratory laparotomy, or endoscopic evaluation of the GI tract.
Okay, Dr. Supa, do you want to take this question first?
One thing that this patient is going to need is exploratory laparotomy because she has an obvious intra-abdominal injury that need to be addressed. And for the hemothorax on the right chest, she had a clotted hemothorax, which should be removed also. I think the standard treatment for this lady should be right thoracotomy to evacuate all the clot and to check the bleeding and to stop the bleeding. And but if the right chest tube doesn't put out much and she becomes stable after ELAP, the other option is maybe put the second right chest tube to and observe the output, or you can also do VAT for evaluation of the right hemothorax.
Thank you, Dr. Supa. I noticed that Dr. Alex has joined. Would you like to be a panelist today?
Good morning, sure, but not for the first couple. Until I
sure.
what's going on since I missed the beginning. I'm sorry.
Sure. Yes, maybe Dr. Nowak can fill you in and then you can join the next round. Okay, Dr. Antrak, would you like to?
Yeah, so in this case, how much was the chest tube putting out during this time? About what, half an hour since the tube was put in? How much came out of the tube?
Pretty minimal output. When I put it in, I only got 150 out, and given the size in the X-ray initially, I tried to reposition it again to get it more posteriorly, but it still didn't really put out very much at all.
And the patient is not needed very much in the way of fluid. She just has IVs, but not really getting resuscitated. Okay, yeah. So this is obviously no ongoing vascular injury with ongoing bleeding. So it's mostly a GI injury, and we would call this basically, this patient is yellow. In other words, a serious injury, but not immediate. And in this case, I think she may need a thoracotomy at some point, but I would be concerned. She definitely needs a laparotomy. I agree with Dr. Supa on that, and apparently she's got damage to the perforation of viscera, stomach, perhaps colon, and so I'd want to limit the operation to that body cavity and take care of those injuries, and then as she recovers, if she needs to have a evacuation of a hemothorax, that can be done. I would do that separately, simply to avoid spreading the infection between body cavities. But so in this case, I would favor exploratory laparotomy.
Okay, Thank you, Dr. Amtrak. Dr. Ruiz, would you like to add something?
Selecting what cavity to go first is probably one of the toughest things in trauma surgery when there's multi-cavity trauma. You have to have into account which one is the cavity that has the highest potential of bleeding and contamination when you make that decision. So, for example, in right upper quadrant penetrating injuries that you see a lot of hemothorax coming out, and it's really the liver, choosing to go to the liver, to the abdomen, is tough, but that's probably the right thing. And you do it because of the bleeding, even though the bleeding is coming out of the chest because of the negative pressure. In this case, the analysis was that this woman definitely had intraperitoneal injuries. The chest tube was in place, the output was minimal. That's a key question, and it was already asked as a key question: how much is coming out of the right chest? And we also had the information from the CT scan that showed us that there was no vascular injury inside the mediastinum. So the place to go is the abdomen. So we set up to be ready for an exploratory laparotomy, but there's also a couple of elements that you need to be sure. Are you going to explore a second cavity? Or the exploratory laparotomy in this case is enough to take a look at the mediastinum. Remember that you can see about 5 or 6, maybe 7 centimeters with great dissection of the esophagus through the abdomen when you do a dissection at the cruise of the diaphragm. The last thing that you need to be sure is that you have some sort of evaluating the rest of the esophagus. So you have to call in either your GI colleagues, or if you have the skills and the equipment, get the equipment for yourself to perform a endoscopic evaluation of the GI tract. So my answer to this would be definitely exploratory laparotomy. That's where the highest risk of bleeding contamination is going to be, according to the information that we have now, but also get ready some sort of evaluation of the GI tract to see if you are going to be able to approach this through the abdomen completely, or if you're going to need a second approach through the chest, in which case would probably be the right side thoracotomy.
Right. Thank you, Dr. Ruiz. Dr. Amtrak, you had something to add?
Yeah, just a comment to what Dr. Ruiz mentioned, and I should have mentioned this in my comments. With a stable patient, I might have also given some oral contrast for the CT to see. You would have seen leakage into the peritoneum, but you would have also been able to determine if there was an esophageal injury or gross esophageal injury resulting in leakage into the chest. But and that would have saved a bit of time. But I think it's totally appropriate. You know, you can do intraoperative endoscopy once the patient is the areas of damage in the stomach or the colon once they're taken care of. I think that's also reasonable.
Okay. Thank you, Dr. Amtrak. Dr. Nowak, do you want to continue?
Yep. I'll just kind of summarize briefly just to catch everyone up who logged in a little bit
perfect.
later. So
yes,
we had a 20-year-old female who came in with a gunshot wound to the right shoulder and then a graze wound on the left breast. She was hemodynamically normal throughout. She had a right-sided hemothorax on her initial chest x-ray, so we placed a right-sided chest tube. And then she ended up going to the CT scanner. This is just a quick cut of that scan with right-sided hemopneumothorax, fluid and air around the distal esophagus, and then a trajectory through the stomach, splenic flexure of the colon, and the bullet lodged here. So kind of got through that last question, talked about the surgical approach, and we did end up starting with the laparotomy. So some images here. Since we did have high concern about the distal esophagus, we needed to get good exposure to the hiatus. So this image here just shows dividing the left triangular ligament to mobilize left lobe of the liver, which we then retracted up to the patient's right to help expose the hiatus. And then this shows kind of opening up the peritoneum over the esophagus. And then eventually opening up pars flaccida, and then encircling the esophagus with a Penrose to help mobilize that further and identify our injuries. So this shows where our gunshot wound tract went. So there was two injuries in the distal esophagus that we were able to mobilize into the abdomen, and then also 2 injuries in the stomach as well. So our intraoperative findings, I think the CT really helped guide us to the injuries. When we first got into the abdomen, there was no real hemoperitoneum noted. And, initially, the esophageal wasn't necessarily apparent. We did notice that there was some saliva appearing material near the hiatus, and given our CT scan, we made sure to really explore that area, and then ultimately did mobilize the esophagus and find those 2 bullet holes there. And then upon running the rest of the bowel, we noted the anterior and posterior gastric injuries, and then injury to the transverse colon as well, and the bullet had lodged near there. So just kind of an open discussion to the panelists on repairing distal esophageal injuries. We kind of talked about how we got our exposure, but any, I guess, pearls and experience with repairing distal esophageal injuries before we go into what we did.
Dr. Alex, would you like to take this question first?
Sure. Good morning, everyone. Well, esophagus, so it's diagnosed basically within 24 hours, so probably not much contamination. Depending on how much destruction of the esophagus is, then you decide if you can do primary repair in 2 layers and drain widely. You also have to basically keep in mind, so you have 2 holes in the esophagus, 2 in the stomach, you have a bullet, something else also needs to be injured. You mentioned the colon, and you make sure you see how that from the distal esophagus got into the abdomen. So it's probably a hole in the diaphragm there too, so you have to look for that too. But if it's not much destruction, I would primarily repair adequately, widely drain, place an NG tube in the stomach. Also depends on how the patient is doing hemodynamically. You may decide to do a damage control and then come back and not do repairs or resections in the setting of somebody being hypotensive. And then you also have to think about enteral access down the road, and probably a feeding jejunostomy may be the way to go here until things heal. You try to kind of save as much as you could as the stomach and not put a gastrostomy tube in case something fails and you have to use the stomach for a conduit for repair later. And then the same goes with the colon. Hopefully you can primarily repair it, if not resect and put it back together.
Thank you, Dr. Alex. Dr. Ontrak, would you like to?
Yes, I think that. Sure. Yeah, I pretty much agree with that, and it's beautifully done. That dissect from below, mobilize the esophagus. You can really get up almost to the carina with blunt dissection, and then pull it down. And so I agree. It primarily this early on, if the holes are small, and primary repair, mucosa and submucosa, and then muscularis for the esophagus, repair the holes in the stomach and with several layers. And then in this case, I would do a partial wrap over the esophagus with the fundus of the stomach. So just divide the short gastric vessels and then reinforce the esophagus that way without doing a complete wrap. For the colon, depends on the degree of contamination, but if this usually at this, within the first 6 hours or so, you can do a primary repair, unless there's a lot of destruction or a lot of soiling. Then the safe thing to do would be either to do a resection or just exteriorize the area of the injury. It seems like basically the splenic flexure just before and just after the splenic flexure is where the injuries are, so you need to mobilize that. You can do a partial resection if you can't do primary repair. And if you're worried about doing an anastomosis, you can always bring the 2 ends up as sort of a miculate stoma that you can close with a single operation later on. But probably in this case, you can primarily repair the colon as well. And then for feeding, you can always put the needle catheter jejunostomy. But in this case, I would probably pass a Dowpaw feeding tube, and put it distally in the stomach, and if you needed to, you can use that, or just a nasogastric tube to keep everything decompressed. Either one, yes. And I agree with not putting a jejunostomy, not putting a gastrostomy tube. I agree with that.
Thank you, Dr. Ontrak. Dr. Supa, would you like to add something?
I agree with primary repair everything at this point because the patient is stable and the injuries are fresh. And for the esophagus, if you could identify two holes through the abdominal approach, you can do the transhiatal repair. And you may reinforce it with, like Dr. Ultrash mentioned, fundoplication, or you use a ton of omentum to wrap around it. And the holes in the stomach and in the colon, I think they could be repaired too. And I agree with Dr. Alex to put in the feeding jejunostomy distal to the injuries. Just in case the repair break, we still have a safe enteral route to feed the patient. Thank you.
Thank you, Dr. Supa. Dr. Ruiz, would you like to make some closing comments?
Yeah, so the decision really depends on the condition of a patient. On a patient that is crashing, that is really sick, there are a few things that you have to do that are absolutely a requirement to do. One is be sure that all the injuries in the esophagus are properly controlled with drainage, because in a patient that is too sick, you probably don't have time to do any repairs. So doing the endoscopy and being sure that there's no transmediastinal in the higher mediastinum injury that is going to be uncontrolled, because mediastinitis, septic mediastinitis is a fatal disease in this situation. So put the scope down, be sure that you have the injuries controlled. Now, if the esophagus is completely destroyed, you're going to have to staple that esophagus off and put a tube in the blind end so you can drain the saliva out. If the esophagus is, the injuries are not totally destructive, but the patient is too sick for repairs, wide drainage of the esophagus, and place an NG tube or a split fistula, which in trained hands should not be a difficult thing to do. Now, in the abdomen, in a situation of damage control, you would staple the two ends of the colon, leave the patient in discontinuity, oversew or staple the stomach, and pack the patient and get out of it. But be sure that you drain the esophagus, because that's what will kill the patient if you leave that unaddressed. Now, in this situation, I totally agree with the comments below, with the comments prior. You might be able to repair everything. Primarily, if the patient is doing fine, you might be able to, you need to be sure that you drain. But again, you have to be sure that there are no hidden injuries in the esophagus before you leave higher up. So it's absolutely required that at this point you scope the esophagus, or you get your GI colleagues to come intra-op and take a good look at the esophagus. And that's it. But it was also important to talk about a situation like this in a patient that is too sick for you to be able to repair. That's it.
Thank you, Dr. Ruiz. I think we can continue, Dr. Nowak.
On the single injury in the colon, we just used a TA stapler to repair that, and then the gastric injuries, we used a TA stapler as well on those. So kind of what we talked about before, so careful dissection at the cruce. Then you want to pull the esophagus down and identify the injuries if you're doing the transhiatal approach, just kind of bluntly mobilizing the esophagus within the mediastinum, and then getting the Penrose around it to help pull it down further and proceed with the blunt dissection. And then we talked about the endoscopic exam. We saw two holes when we were able to mobilize it into the abdomen, but again, we performed an endoscopy and didn't find any injuries more proximal to the esophagus. Debridement and two-layer repair. So debriding any non-viable tissue, making sure that you have visualization of the full extent of the mucosal injury prior to repairing. And then we ended up repairing it in 2 layers of absorbable suture just to help try to prevent stricture from forming. So we used Vicryl for the inner layer, and then PDS for the outer layer. And then as far as performing your fundoplication, again, we did a toupee fundoplication, like not a complete fundoplication. Typically this is done over a bougie. We did make sure that we mobilized the esophagus enough to get 3 centimeters in the abdomen. Just kind of from remembering from residency and elective surgery, you really want to make sure you have a good 3 centimeter tension-free intra-abdominal esophagus prior to performing your fundoplication. And then this image here shows the 2K fundoplication. So wrapping it around the esophagus, again, making sure that you're not wrapping fundus around just GE junction, that it's really on the esophagus itself. And then the wrap itself is about 2 centimeters in length. The short gastrics have already been divided in this image in order to do that shoe shine maneuver and get the fundus around posteriorly. And then again, that should lay in place without any tension. So, once you pull it around, you want to make sure that it's not retracting back over. And we ended up, I think, needing to mobilize along the greater curve a little bit more to make sure that it was sitting in a good position. And then when we were suturing it in place, this kind of shows, I think, the anterior vagus is right down the middle there. So making sure to avoid incorporating the anterior vagus into your repair. And then, as said, we ended up placing a nasogastric tube and a distal feed tube that we fed through in the OR and sutured those in place to the patient's nose so they wouldn't fall out. But again, we had discussed potentially putting in a GJ tube or just regular NG tube and a feeding J tube, but decided just to do the nasogastric and nasoduodenal tubes. Some technical notes here, being careful in dissecting the short gastrics, which are here. Using a bougie for sizing, if not available, using an endoscope. We were going to scope anyways. We had the scope in the room and we didn't really want to be passing our bougie past these injuries that we had just repaired. So we did the scope, put the sutures in place, tied those down, and then ended up just using that. So rough sizing wise, for elective surgery, they talk about using like a 52 to 60 French bougie with the NG tube, and the scope kind of adds up to something similar, almost 50 French, and then just making sure there's adequate laxity there. The endoscopes are typically 9 to 11 millimeters in diameter, so that's equivalent to 30 to 34 French. And then leaving drains in place, as we talked about, we ended up putting one kind of anterior and one posterior to the wrap, and then washing out the chest and draining. So we had ended up doing kind of a mini thoracotomy on the right side and just suctioned out the hematoma and ended up irrigating out the chest and placing a curved chest tube a little bit, tracking more along the diaphragm to get the rest of the hemothorax out. And then just other things, whether to do a door, Nissen, fundoplication, whatever it is needed to cover the injuries, or as other people had mentioned, bringing up a buttress of omentum if you had too many injuries along the fundus to mobilize that and use that for a wrap. And then other things that we talked about was whether you need to close the hiatus any further. Her esophageal crura looked like, or her diaphragmatic crura looked like they were intact and there wasn't really an obvious defect there, so we didn't end up doing any cruroplasty. But depending on the amount of mobilization that you had done, you may need to do a couple sutures reapproximating the diaphragmatic crura to prevent a hiatal hernia. And what else? I think that's mostly that for this. So another question for the audience. So what would your plan be postoperatively for care of the patient? Would you keep your NPO for 2 weeks? Would you take out the NG tube and start a diet? Obtain an esophagram and then start liquids if the esophagram showed good passage and no leak? Or perform a repeat endoscopy and then start clears at a week post-op?
Thank you, Dr. Nowak. I see that Dr. Frisbee has also joined the meeting. Dr. Frisbee, would you like to be a panelist today?
Well, I think I've seen this. I think I've seen this motion picture before. Let's see. What would I like to do? Well, the esophagram is going to show you a little bit more than the endoscopy. I probably would take number 3. But that's all I've got.
Okay, thank you, Dr. Frisbee. I see that Dr. Ginsberg has also joined. Dr. Ginsberg, can you hear me? Would you like to be a panelist today?
I already know this case.
Okay. Okay. So I'll go back to Dr. Antrak. Would you like to?
Sure, yes. I agree with Dr. Frisbee, although I wouldn't set arbitrary time limits. In this case, I would wait and see how she does. As soon as she starts to have bowel sounds and feels hungry and, and has bowel movements and everything's okay. And that might be 3 or 4 days, because she was stable. You took her right to the OR, you closed all the holes, before her body even realized she had perforation. So, but I would certainly do a barium swallow or gastrographin swallow. If that's negative, then do a barium swallow. Just you can check to see that there's no your fundoplication isn't too tight, that she can swallow properly, and then start her on liquids. But that could be as early as 3 days. If you do an elective laparoscopic Nissen fundoplication, it can be the next day or the day after that they start some liquids. So it's but basically number 3, and timing by how she evolves clinically, how her ileus resolves, and judge that way.
Thank you, Dr. Drack. Dr. Silva, would you like to say something?
I agree with number 3 also. And because she has distal feeding route, we don't need to rush the patient to take oral diet. And I think esophagogram is safer than endoscopy after you repair the esophagus. Thank you.
Yo le voy a decir, yo como no tengo mal micrófono.
Thank you, Dr. Silva. Dr. Alex, would you also like to add some comments?
Yeah, nicely done in the repair and the feature that you showed. Of course, you want to use a bush, make sure you don't narrow the esophagus, and with the esophagus always you try to bring some healthy tissue on top of it to prevent any problems. So it's nice that you were able to bring the fundus of the stomach for that buttress. I would definitely go with a esophagram before deciding if the tube comes out and the patient needs to be fed. I agree with the previous comments, not necessarily about an arbitrary like a week, but based on how the patient is doing clinically, and probably as early as day 3. This is not a radiated field or a patient that got chemotherapy where you want to be a little more careful or wait longer. Yeah, that's it really. And I would keep all the drains in place until I get the study, and then start pulling slowly things out. Just make sure there's no leak and the repair healed. And with regards to the jejunostomy, I guess the patient didn't need it. That's great, but sometimes you can get away with it. If you think you may need it, you may be able to tack a small loop of bowel to the abdominal wall, put a clip or 2, and then have IR access that, so you don't have to go back in the belly. Yeah, very nice. Thank you.
Thank you, Dr. Alex. Dr. Ruiz, would you like to make some comments at the end?
Yeah, thank you. I apologize if you hear my dog barking here, but anyway, so the esophagogram is probably the best option here. It's going to give you not only information about leak, but it's going to give you the functional functioning of the functional work of your wrap and the emptying on the stomach, which is key to see at this point. I agree with the timing. What I did was just to be sure that your drains in the mediastinum are giving you information on whether the patient is ready. If you start seeing a lot of drainage through the mediastinal JPs, in that case, you're probably going to send amylase to be sure that there's no saliva in the mediastinal drains, and that's going to give indication that there's still an ongoing leak and make you wait a little bit longer. In this case, things went remarkably well, and I don't think we actually did a week. I think it might have been shorter than a week, but we decided to go to number 3, which is doing the esophagogram.
Okay, perfect. Thank you, Dr. Ruiz. Dr. Nowak, I think you can continue.
Yep. So here is actually a video of our esophagram. I think we did it post update 5.6. This works. So you can see it passing through, and you can kind of see where the NG tube is still in place, but everything passes through and continues on to the stomach. You can actually see our distal feeding tube there on that image as well. So based on the esophagram, at about a week post-op, we took out the NG tube and started clear liquids on the patient. Her chest tubes and her drains were in place until after that swallow study, as someone had mentioned. So then we ended up starting to take out the chest tubes, initially the apical one and then the one along the diaphragm, and her abdominal drains prior to discharge home. And then she was advanced to a pureed food at week 2 and a soft diet in week 3, just giving some time to make sure things pass through the fundoplication. So that is what we have for the case. I guess I'm happy to take any questions or hear any final comments from everyone.
Thank you, Dr. Nowak. Dr. Supa, would you like to make the comments first?
Because she has a hole on the right side of the distal esophagus, did you look for a vagus nerve? And if the patient have a vagus nerve injury, would you do something to drain the stomach? Just asking.
So we were actually able to see both her anterior and posterior vagus nerves, and they appeared intact. I think as long as one of them was intact, we wouldn't do any additional drainage procedure for the stomach.
Thank you, and a very, very great case. I learned a lot. Thank you, Gabe.
Thank you.
Thank you, Dr. Supa. Dr. Alex, would you like to make any comments?
A great case, and thank you for presenting it. My question is, was there any injury to the diaphragm? I guess if not, then the bullet kind of found its way to the abdominal cavity through the esophagus and stomach.
Yes, we didn't see any injury to the diaphragm, surprisingly enough. So it must have just snuck through kind of at the esophageal hiatus.
Thank you.
Thank you, Dr. Alex. Dr. Frisbee, would you like to add something to the case?
Well, only this: esophageal injuries are, you know, everybody's idea of, hey, a great case. But if you miss the injury, you will have many, many sleepless nights. It's a devastating injury to have, and especially if you're in there and you happen to just, through no fault of anybody, just miss one of the injuries, it's going to be with you. You're going to be married to that patient for a while, because it's not going to go away overnight. So just take your time and be very methodical about it. The case was good. The case was, what I heard of it was very good. Thank you.
Thank you, Dr. Frisbee. Dr. Ginsberg, do you have any additional comments?
Just a fantastic case. Oh, very well managed. Beautiful. You know, I was very impressed.
Thank you, Dr. Ginsberg. Dr. Antrak, would you like to add something?
Yes, I agree. Beautifully managed case where you immediately, you know, the patient came in. Luckily, he was a very considerate assailant. If he had shot more this way instead of that way, he would have transected the aorta, and the patient wouldn't have come to you. But and just the evolution of the patient. The patient came in awake, was stable the whole time.
Really rare injury, and that. Having seen this injury during fellowship is probably going to be the last time that she's going to see it during training. So now she's got a great experience. The second one is I agree with the comments. Knowing that there's no other injuries in the esophagus is absolutely key. I'm not sure if you can hear me. Can you hear me? Yeah. Knowing that there's no other injuries in the esophagus is absolutely key, because I agree. Missing an injury in the esophagus is an absolutely terrible situation. And the last one, that approaching these injuries through the abdomen when they're distal are probably the best option. They're not technically difficult to do, but there are rare things that we do as trauma surgeons. So bringing all that knowledge from general surgery every now and then is very satisfactory. I want to thank everyone and Dr. Nowak for this nice presentation.
Thank you, Dr. Ruiz. Yes, thank you, everyone, for all your valuable comments. Thank you, Dr. Nowak, for presenting the case. Is there anyone else that would like to add something? Anyone who has any questions that we can address? Okay.
I think
if
for
not-
for the next meeting we can have Uri as a panelist now, joining us from Israel, and I'm taking a look at here at some other people that have been with us in the past. So I'm happy to see you all. Thank you very much.